Good morning. This is the voiceover PowerPoint for Chapter 19. So we are going to talk about different types of obstetric procedures in this chapter. The first one we want to talk about is what's called an amniotomy. When you see the suffix otomy, that means make a hole in, okay, or open. We do amniotomies. We deliberately open or rupture the membranes, and as a part of inducing labor. And we also, if the woman is dilated at least 2 centimeters, remember, we can rupture her membranes and we can put in internal electronic fetal monitoring devices if necessary. The risk, of course, especially if the engaged part, the head, is very high, like a -3 or 4 station. If that head is not down and we rupture the membranes, there is always a risk of the cord floating down to around the presenting part and going past it or in front of it, and then as the head descends, it's going to be compressed. And we'll talk a little bit more about this in another session, but that is a very, very dangerous situation. Anytime we open up the cervix, if the cervix is open and we rupture those membranes, that is the last defense against infection. And so when a woman is pregnant, 27, 28, 30, 32 weeks in that area, and her membranes rupture prematurely, they typically either make her stay home on bed rest, or they may even bring her in to the hospital until she delivers, because if an infection sets in, that is dangerous to mom and to baby, which can be, it's called chorioamnionitis, okay? And we can also cause something called abruptio placenta, and we'll get into that another time. But the biggest risk is the prolapse cord and the infection. Let me go back here. One thing we want to do before we do an amniotomy, of course, is to make sure mother understands what we're doing and why we're doing it. We also need to make sure we have a good fetal heart tracing, that we have good steady variability, accelerations possibly, and we want to make sure when we do the amniotomy, as the fluid comes out, we look at the color, the consistency, and any odor to it, okay? And even sometimes if we're suspecting maybe a smaller amount of fluid than we would like, we may watch the amount as well. So the fluid should be kind of a clearish to a slightly cloudy whitish yellow. It may have a little tint of green. It may have big chunks of meconium. It may be green as pea soup. If we have meconium, we need to let everybody know, because that's probably going to mean the baby will will not be allowed to cry. They'll look at the cords, clean out the cords. They'll take a laryngoscope looking down there, suction all that gunk out before they let the baby cry, because when the baby cries, it could suck all that into their lungs and they can aspirate, and it'd be very deadly. And so that baby will probably be resuscitated and possibly in the NICU overnight if need be. So we're watching that fetal heart rate after this procedure, and we're looking at the color, and then we'll go from there as far as her contractions and so forth. Pardon me. So sometimes we induce or start labor. Many times we'll do this if a woman's getting closer to term, maybe 37, 38 weeks possibly, and she's having trouble with her blood pressure. She's getting a little eclamptic. Maybe she's diabetic and the baby is going to be huge if we don't get it delivered soon. We don't induce to suit the doctor's schedule or to suit the mother's schedule. We don't do this. We stimulate contractions for the purpose of bringing about birth. It can be done electively, again, if it's indicated, or, like we're going to just, last time, maybe mama has already had a baby, maybe last time she was in labor for 2 days and it was really rough, so we're going to go ahead and induce you and make sure that we take care of this and so forth. Or again, maybe we're having problems with blood pressure or so forth. So there may be lots of reasons to initiate labor. What's the matter, kitty? My kitty is talking to me. Okay. inducing labor or augmenting or helping out. Augmenting means helping out. Fetal compromise. Maybe we have some intrauterine growth restriction, or we have a case of RH incompatibility. Mama is RH negative and baby's RH positive, or vice versa. We have a spontaneous rupture of membranes near term, and so we don't want her to just walk around with, we want that baby to come. Post-term, in other words, she's 42 to, she's way past her due dates. We need to get the baby out. We are suspecting, or we have confirmed chorioamnionitis, like we talked about a while ago. The hypertension. We also have maybe some maternal conditions that we're worried about. Her diabetes may be out of control, other issues. And then a fetal death, or we call it a fetal demise, D-E-M-I-S-E. The baby has died in utero, inside. We have to induce labor to deliver that baby. We don't go in there and cut it out. That's more dangerous and not as healthy for mother, believe it or not, than having it vaginally, if at all possible. And there's a lot of reasons babies can die in utero, and we're not going to get into that right here. Contraindications for induction and augmentation. Placenta previa, which means the placenta has implanted in an awkward place inside, and possibly as in an area where, as if the cervix starts to thin and dilate, it will actually pull the placenta away, and the placenta will try to come before the baby gets there. Okay, a vasa previa typically means that we're very, very similar to a placenta previa. We would not want to stimulate labor. An abnormal presentation, a shoulder presentation, possibly a footling breach. We suspect umbilical cord prolapse, or we have one. Previous uterine surgery, particularly the old-fashioned type of cesarean section where they actually went up and down instead of at the bikini line. That can make the uterus more prone to rupture. And then we're monitoring baby, and even with maybe with slight augmentation or without, we're watching baby, and we have minimal variability or none, or for some reason we have some strange variables. We would not want to induce labor. That baby will have to be born cesarean. So to decide to use another method of augmentation, what we call cervical ripening. So let me explain that. A cervix in pregnancy, especially at term, the membranes are intact, you've got your mucus plug in there, and your cervix is very thick and it's long. It kind of feels like a stem almost. Okay. We also have a score here, and to determine if the cervix is ready or ripe for other types of chemical agents that we can use to stimulate labor and cervical dilation and effacement, we use something called a Bishop's score. Okay. So you can see here, we give it a score from 0 to 3. Maybe we're evaluating the cervix for ripening, and we're just evaluating this patient, seeing where she's at right off the bat. You see here, this was modified in 1964, but it's still used. Same identical thing. So we're looking at dilation, and you see the farther she's dilated, she gets a higher score. Effacement, how thin or thick her cervix is. The fetal station, remember we talked about the 0 station is at the presenting part, or the head hopefully, is at the level of the ischial spine. So above that is a minus. So a -3, that head is way up. It's not engaged, okay? And so part of the dilation and effacement of the cervix happens because the baby's head is pressing down on it as well. And then you see as they advance, they get higher scores. Cervical consistency, okay? Is it firm? Is it thick? Or is it soft? And then the cervical position. Typically, the opening of the cervix goes most posterior early in pregnancy, and then as it starts to get later, it will move around to the anterior. So if you were to examine the cervix in a 32-week pregnancy, which you would not be doing probably, but you would have to reach way back toward the mama's back to even find the cervix, because that's a protection mechanism to keep the pregnancy in for that. And then, of course, things can happen. So delivery of the woman who is having her first baby is more successful if her score is 7 or above. If she's already had a baby, 5 or above. So the nurse or the physician may actually evaluate the cervix and give the patient a Bishop score. All right? It would probably be a good idea to know that a primip, or a woman who's having her first baby, needs a 7 or above. A woman who's already had a baby needs a 5 or above. I would advise that. So here we go. More techniques for induction, like we were just saying. Cervical ripening, medical methods. Okay? Medical methods. We use prostaglandins. And if you don't know what prostaglandins do, you need to go look it up. All right? We can use a medicine called misoprostol, which is also known brand name as Cytotec, Cytotec. It is actually used to prevent NSAID-induced peptic ulcers. But we can actually take the tablet, insert it right up to the opening or the tip of the cervix, and it will dissolve and stimulate labor. We don't give misoprostol to women in their first or second or even mid-trimester because it can actually cause uterine contractions and abortions, miscarriages. So we don't do it in that instance. Only at term pregnancy, and we're trying to ripen the cervix. Another one is called Cervidil, which is usually a gel. We put these in women. They're either supine or in the lithotomy position, and they have to lay that way for about an hour. So make sure that whatever we put in there stays where we want it to. We also have mechanical methods. We call these transcervical catheter. You'll hear nurses call it a Foley bulb. It's very, very commonly, it's a whole lot like a Foley catheter. And it's a bulb that is inserted into an already possibly dilated cervix. And the little balloon was blown up, and then we could add to it, blow it up more, and it kind of forces, or if you will, or puts pressure on that cervix to open or dilate. A lot of women have said this is not a very comfortable position, and I have not seen that used near as much, but it can be. Again, lots of times it's doctor preference, but the prostaglandins is pretty common. The other technique we use is the oxytocin or pitocin, or what you hear nurses call it PIT. Okay, we dissolve this medicine in an isotonic solution, and it is given as a secondary infusion. So we always have an IV started, a regular IV, maintenance IV. We call it the main line. It's usually lactated ringers or possibly normal saline. And then we have this pre-mix bag. Typically, we add so many milliunits of pitocin to that bag, or it comes pre-mixed from the manufacturer, and we piggyback it or add it onto the existing line through its own pump, because we never want the pit drip to be primary, because if we turn it off, we want it gone. Okay? We also make sure that we attach it to the port that's closest to the woman's IV site, because that way it doesn't mix in with the other fluid. It's already diluted. We don't want to dilute it more. It will be more effective in that instance. So when we're doing a pitocin drip, we don't have to have a consent, but we do have to talk to mama about it. And if she's not very informed, we will tell her what it does, what she can expect, especially. Excuse me. Okay? When we are stimulating uterine contractions, or if we are not, we always watch baby's response to those contractions. We've talked about early decels, late decels, variables, and accelerations. We never ever want to see fetal bradycardia, because that'll scare everybody half to death. If there's fetal bradycardia, remember it's from 110 to 160, we're talking 110 and below, and that's very scary. On the same token, a higher heart rate can be just as bad. Lots of times tachycardia can occur as a response to labor contractions, and it can also be present if mother has an infection. We're watching for those two especially, and late decelerations and or variables. We also want to watch mother's response, because some women are very, very sensitive to pitocin, and they start cranking out contractions like nobody's business, and we call that tachysystole. They come too fast, they don't have a resting tone, they don't have enough time in between for the uterus to relax, and so we have a compromised blood circulation to the baby, which is going to maybe make this baby respond with bradycardia or whatever. So we need to watch, and if that happens, we need to either slow the pit way down or turn it off. So you'll have protocols, and I have some protocols from Freeman that they use, and I'll share those in class about what you should do if this happens. So here's a strip with, at the bottom here, as you see, this woman's getting very, very little time in between contractions for that uterus to relax and for her to relax and get regrouped. Now the baby has very minimal, very minimal variability. There's no D cells, but that minimal variability can be an indication of a problem just as much. So we're gonna slow her down if we can. Now here's another one, and look what that baby's heart rate's doing. Wow, late D cells. See those to the right of your contraction, and they plummet way down in there. They recover, but it takes them a while. We need to get that mama on her side, turn her IV up. I learned last night at Freeman that they don't necessarily say you should give them oxygen, but in my opinion, I don't think it would hurt anything. They say it doesn't do much good. I don't know. But, and then you call for help because you may have a situation you will definitely not be able to handle by yourself. Okay, this is from your book, exact verbatim, what to do. Reduce or stop the infusion, increase the rate of the primary. That's why you always have a primary. Keep the laboring woman in a lateral position. Give oxygen. It says here in your book to give oxygen. And of course, notify your provider. And then you see signs up above. So this is very important to know. Very important. Thankfully, it doesn't happen very often. Sometimes we do things called version. In other words, we try to turn the baby from the outside to a better birthing position. I have a mixed feeling about it. It's problematic. I've only seen a few doctors try it. We do it externally to turn the fetus from a breech or shoulder presentation to a vertex. Okay, we have to have an ultrasound during the procedure. Before we ever start this, we have to have a non-stress test with a reassuring response, okay, from the baby. We want to see accelerations. You remember that from the NST. And the woman has to sign a consent, okay? I've seen it work, and then I've seen it work, and then babies flop right back to the way they were. So it could be either way. Contraindications to this is, we're worried about uterine rupture, we've got blood pressure problems, all kinds of things. So again, those are in your book. So we do this externally. We have to do the Leopold's maneuver, and doc tries to put pressure on one side or the other. This is not a nursing procedure. This is an obstetrician who does this. Midwives, I don't believe, are allowed to do this. Internal version, they actually reach up in there and try to get it. That's ridiculous. High morbidity. Now, sometimes they use it in twin gestations. During labor, they reach up in there and try to turn the baby so the second twin can get out. But again, that's questionable. It's rather barbaric in my opinion. Okay. Operative vaginal births, that's where the provider applies traction to the fetal head. Okay, the head might not be stuck, but there's something impeding the progress of the head. Okay. Forceps are used less frequently nowadays. Now they use vacuum extraction. I don't like either one of them, but anyway, they can also put forceps on a baby to help get the baby out of the mama's abdomen through the incision of a C-section. Here they are, okay? They look pretty awful, but in the hands of a skilled obstetrician, they are very, very safe, okay? And they just apply them right around over the ears, right on the cheeks, kind of, and they close them, and with a contraction, they try to pull the baby. And with a contraction, they try to pull the baby and get that head out. Not used as commonly as once were. The vacuum extractor, and I'll show you one in class. Again, you have to have a skilled obstetrician who knows what they're doing. They are not without their issues. You can cause cerebral hemorrhage and all kinds of bad stuff. So neither one of them are without issues of safety. But they can be used safely in the right setting with the right person. This is the kind we have in our lab. So, and they use the little pump there, the picture A. They squeeze those two little things together and apply suction. Very interesting. And the little cup thing goes on baby's head. All right. Trauma associated with operative delivery. So if mama does not have an episiotomy, we apply vacuum or forceps especially. She's going to lacerate. And those are listed in your book. First, second, third, fourth degree lacerations are in your book. Hematomas. Infant can have bruising. They can also have lacerations and abrasions on their face, which go away, but they look awful. Facial nerve injury, possibly because of the placement of particularly the forceps, and the intracranial hemorrhage or subgleal hematoma as a result of, can be forceps, but more commonly associated with vacuum extraction. Episiotomy is an incision or a cut of the perineum just before birth. Some doctors don't do these anymore. It reduces possibly perineal lacerations and tearing, but sometimes they're not done typically like they used to be. But however, if you have a shoulder dystocia, in other words, the shoulders are stuck, the head's out, but the shoulders cannot be delivered, they will cut what they need to cut to get that baby out. Sometimes if we use forceps or vacuum assisted, we use an episiotomy. And the fetus is in the occiput posterior position. They'll have to have something to help get that baby out because, again, it's not coming in the right presentation. So here's the episiotomy, midline, where they cut right straight down from the vagina toward the rectum. And then the other is they cut away from the rectum. Forgot what it's called. Lateral. Medial lateral. Okay. And once these are cut and the babies come, then they are sutured back together with that local anesthesia possibly. And if there's a laceration, the doc may decide to leave it and let it close on its own, or they will sew it up. Cesarean birth is the birth of the fetus through a transabdominal incision of the uterus to preserve the well-being of the mother and her baby. Okay, they are doing quite a bit. This is probably not even accurate now. 32% of all births were C-section in the early 2000s. I think that's wrong. I should have looked that up a little bit more. A VBAC is a vaginal birth after cesarean. So we used to say if you had a cesarean once, you couldn't have the baby any other way. But now there have been some women who had a cesarean who successfully delivered vaginally in their next pregnancy. A TOLAC is a trial of labor after C-section, and sometimes babies don't tolerate it. Mama changes her mind. They'll do a little trial of labor and see how she does. It's called a TOLAC. High rate of cesarean repeats. Increasing obesity is also a factor in it. Increased induction rate, also maybe because they'll do an induction and nothing happens and she doesn't progress. Oh, she failed induction, we got to section her. And then lots of times women delay childbearing and then they get into trouble and they have to have a section. The low transverse, or the bikini cut they call it. So there's the vertical and then there's the transverse. Okay, they call it the Pfannenstiel. It's less visible. It's a little more difficult for a doc to get in there and get the baby out. Now, the one on the left, the vertical, if we have an emergency or we suspect a uterine rupture, they're going to do the vertical. Okay, they're not going to mess around. They got to get in there quickly. And anyway. And then she'll have a scar. So here's how they do a section if you haven't seen one. Letter A, they've got the abdomen open. They're reaching in there to get the baby. the baby's out and they're looking at it and they're going to clamp the cord. They're clamping the cord in letter C, and they're drying the baby off, and they got, if they need a resuscitation or whatever, then they'll hand the baby off to the nurse or the neonatologist or whatever is indicated. So a C-section, we treat it like a general surgery, abdominal surgery. The immediate post-operative care, we're watching the vital signs very, very closely. We're watching the postpartum, doing the postpartum care, watching that fundus, watching the bladder, watching the bleeding, all those things that we already do. But remember also in a C-section, you also have an increased risk of venous stasis and possibly clots. So you may have STDs on her, TED hose, or both, okay? We're going to try to promote bonding because you can see that top picture there. Daddy's got baby and mama's awake. They are awake during the cesarean unless they have a general. So we need to watch our conversation. Not talk about use profane language and inappropriate stories and so forth. Although it happens, I'm sorry to tell you. So we try to, if we can, we'll put baby up next to mama, skin to skin if possible. It just depends on your baby situation and what's going on. If everybody's stable, we're going to go after that. And you're going to do everything that you would do for this postpartum patient, except you got an incision to watch out. You're probably going to have a Foley catheter to manage. You've got pain management. You've got maybe helping her breastfeed. So you're doing all the things that you would do, but you're adding in the surgical piece. And then, of course, we've already talked about trial of labor and vaginal birth after C-section. Here's the VBAC. A lot of women just feel like, oh, I wasn't very good. I didn't tough it out. I had to have a C-section. That's not true. And this tells you about the VBAC. And if they want to try it, they might want to do a trial of labor, and we'll see how things go. So it just depends on your woman, her goals, and so forth, her situation.